Hi, good morning. Good morning, everyone. And let's go ahead and get started. John Samet, the interim chair of the Department of Environmental and Occupational Health and chair of the search committee for the next year. If there's somebody who would like to start tomorrow, that is entirely possible. So I'm pleased to introduce Tamara James Todd, who's speaking with us today. Tamara is at the Harvard T.H. Chan School of Public Health. She trained in public health, receiving her MPH at BU and her PhD at Columbia. Her work is focused on reproductive and childhood epidemiology. She's investigated a very long list of agents and health outcomes for the fetus and for children, publishing more than 100 papers. Unfortunately, the world keeps bringing her more and more to study. So she is very busy with this work. She is involved as PI for the Community Engagement Core of the Superfund Research Center at Harvard, and she's deputy director of the Harvard Chan NIEHS P30 Center. She has served on a variety of committees that are important translational bodies, including the Board on Population Health and Public Health Practice at the National Academies. She was recently on a committee chaired by Ned Kalanj that had a challenging task related to trying to understand what blood levels of PFAS mean and how to explain to those who had their levels measured and those clinicians who were involved in following up what this all means. And really a challenge. And of course, if you've looked at the papers in the last few days, you've seen that the Environmental Protection Agency is now calling for cleanup of some of these compounds. So we're delighted to have you. Oops, I just advanced your talk. We're delighted to have you here with us, Tamara, and look forward to your talk.
Thank you so much for having me. And it's a beautiful day, really excited to be here. So today I'm going to be talking a bit about my research and the approach that I use in my lab and in my science that I'm really hoping that we might be able to consider doing together. So really thinking about the way that we can take a solution-oriented approach in achieving environmental health equity, and I'm embedding it into the work that we do in the context of environmental reproductive justice. So first, I want to provide you all with a framework of how do we think about health equity in the context of environmental reproductive justice. And then I want to give some background as to why I'm using this particular example, and then providing you with some examples and some way forwards in the context of the work that I'm doing. And hoping that you all will consider as far as thinking about how we can make public health for all in the context of specifically environmental and occupational health. So this particular model of what is a health equity approach was proposed by the CDC in 2022, and it makes us kind of come into, or take these various factors into consideration that both address the historical and contemporary injustices that we may see around us, as well as thinking about ways in which we might be able to eliminate economic, social, and other health barriers, how we can think about overcoming various obstacles to safety and to adequate health care, and how we might be able to approach eliminating preventable health disparities. And embedded in that are questions around what we value and being able to see and value everyone and having an intentionality with respect to thinking about the intersection between environmental health and social determinants, and then really being able to acknowledge and address both ongoing public health threats, but also being nimble enough to consider what might be on the forefront, what might be, coming down the pipeline. So this is a framework that we kind of set up in our lab, and that I've been teaching about in a variety of different settings, ranging from both at Harvard Chan School of Public Health, but also in a variety of courses that I teach outside of Harvard. really thinking about this as like a pyramid with the idea that there's a goal in mind. If the goal is to make sure that we can improve the health of all, how might we take what we observe in the world around us to think about the questions that we very commonly value and ask, such as what are the exposures, whether you're talking about specific exposures that are impactful in the context of climate or in the context of environmental chemicals or metals, but who are most exposed and who are most at risk of associated diseases or health outcomes. Where might this be ongoing? When might there be a sensitive window in time? How might particular exposures impact health and disease risk? And really saying, okay, at some point, we've garnered enough evidence that we need to move on to thinking about the solution to this. And part of thinking about those solutions is asking the question of why. And so asking why can help us identify the drivers of environmental health inequities for intervention development so that we can move on to really being able to design and test out possible solutions and thinking about ways in which we can do that within particular communities, populations, be it a rural setting, be it other marginalized communities that really could benefit from the work that we do. So I want to give you the example in the context of reproductive health and thinking about pregnancy related mortality. So we know in the United States that there is an ongoing maternal mortality crisis. For some, like we've heard about this over the last few years, but few know that this is actually increasing, this is growing, and it's growing in a number of ways. I'm just showing you here a snapshot for by race ethnicity, but this is also increasing in other settings. So this is just something to think about. And the question is oftentimes, and again, thinking about the why, like we've seen this story over and over again, but maybe we can do something about it in thinking about the work that we do. So one way to kind of dive more deeply into this is to consider what is, the traditional question of what might be the main drivers, what's causing these differences. And so if you look more deeply into this, cardiovascular related risk factors are actually one of the major drivers of these disparities. So we see particularly after delivery, this increase in cardiomyopathy. And again, what might be actually going on there? So I think about this in the context of something called pregnancy as a stress test. And this idea was really thought of some time ago in the context of thinking about preeclampsia, hypertensive disorders of pregnancy, but you can translate that to other health outcomes. I'm going to, on the y-axis, you're looking at the increasing kind of vascular dysfunction that may be related to the development of cardiovascular disease. And in the blue, there's in the red represent two different populations. Those populations may differ for a variety of reasons. It could be differences in socioeconomic status. It could be differences with respect to, other kind of family history, biological factors, but it could also be differences with respect to environmental factors. And this is often left out of the conversation when we're talking about health inequities and we're trying to figure out what's going on in the context of pregnancy health. And so here, what I'm showing you is the blue represents a population of individuals that are generally average risk, maybe overall healthy for a variety of reasons. And the red represents individuals that, for whatever reason, have a higher risk. And this black line in the middle represents a clinically relevant threshold for which if an individual crosses that clinically relevant threshold in pregnancy, they're diagnosed with a hypertensive disorder of pregnancy for this particular graphic. And outside of pregnancy, they're diagnosed with cardiovascular disease. And what you'll note is that the red population, this population that for whatever reason has kind of more elevated risk, they cross that clinically relevant threshold in the context of, and again, for parsimony, I'm suggesting that there's two pregnancies that are experienced by both populations. They cross that clinically relevant threshold twice in the context of this. And they also, outside of pregnancy in midlife, develop cardiovascular disease at a time point that's much earlier and oftentimes is synonymous with more severe disease. And can we do something about that? Again, as environmental health scientists, might there be some solution where we can utilize targeted screening or lifestyle modification or early treatment that could somehow reduce the risk in subsequent pregnancy, but also delay the onset of disease And it's worth noting that cardiovascular disease is the leading cause of death in individuals worldwide. And so what might we be able to do with respect to this? It's also worth noting that there are differences in the context of pregnancy and thinking about pregnancy as a stress test that relate to diagnosis and development of pregnancy complications like gestational diabetes due to the increased insulin resistance that occurs during pregnancy, obesity, preterm birth, and hypertensive disorders of pregnancy. And all of these changes, this increased inflammatory profile, altered coagulation factors, and changes in lipid levels and altered vasculature are happening in order to maintain the health and development and growth of the fetus. But in the context of, whatever social or, in our case, environmental factors may be occurring, could there be some sort of perturbation that occurs that actually leads to, some sort of altered impact? It's also worth noting that the development of these pregnancy complications are associated and linked with the development of later life sequelae, including cardiovascular disease, but as well as kidney disease and diabetes development. So I mentioned to you all that in the context of thinking about these factors, oftentimes folks focus in on lifestyle and demographic factors, and albeit very important, ranging from family history to smoking, obesity, and socioeconomic status. There's also been increased attention around reproductive health, inclusive of not just pregnancy complications, but thinking about menstrual cycling. And there's been some unrecognized or less recognized factors, including some of the things that we study in this room. And so thinking about how those connect and how they may interact and intersect with some of these more kind of traditional risk factors. So I work across teams thinking about this in the context of a variety of environmental factors. And that ranges from thinking about air pollution to toxic metals, climate change, and chemicals. And today I'm going to focus on chemicals just to kind of bring home the message of how we might be able to bring forward a solution-oriented approach to the way that we do science. And so specifically, I'm going to be talking about endocrine disrupting chemicals in consumer products. And there are a variety. I'm probably preaching to the choir. You all are familiar with this. But in thinking about the broad swath of different things that we use and are exposed to, ranging from pesticides to plasticizers, things like phthalates, to surfactants, what John and I spend a lot of time thinking about with PFAS, phenols, and flame retardants. I'm going to focus on plasticizers and surfactants for this particular talk as far as an example goes. I wanted to give you the background of what this idea of pregnancy as a sensitive window, not just in the context of the development of pregnancy complications, but also that later life trajectory, because I want to set the stage for really being able to think through where might we be able to identify different opportunities for solution. And so there's certainly thinking, pre-pregnancy, but also thinking about what we might learn from the pregnancy and then how we might be able to alter this trajectory. Because if we really believe that folks who go on to develop any of these conditions, what might their impact be on their long-term health? Might there be a way that we reduce endocrine disrupting chemical exposures that are from some of these chemicals that could then lower the burden of disease and particularly cardiovascular disease risk? Okay, so getting to these two examples. So when we're thinking about, and I'm going to have us work up that pyramid. So we're going to start with the observation. I want to show, the observations that we've seen in kind of repeatedly with respect to environmental exposure inequities. So the first is from a study, a pooled analysis of about 6,000 pregnancies. The focus of this study that was done by Barrett Welch and led by, I was one of the investigators on this team, but led by Kelly Ferguson at NIEHS, was really to understand the role of phthalate exposure as it relates to preterm birth. And what I'm showing you here is just different urinary phthalate metabolites, some of which come from fragrance products such as the top monoethyl phthalate, MEP, associated with fragrance-related products, the metabolite of diethyl phthalate, and some of which are kind of from like food packaging and other consumer sources. And what I want you to note or bring your eye to is that you see these differences in the percent difference as it relates to non-Hispanic white individuals, with Black and Hispanic Latina individuals having much higher concentrations of some of these chemicals compared to other individuals. And I will say to you that time after time, we've seen these types of exposure science publications where you see these differences, but thinking about what can we do about it, I think is important. I also just want to highlight that if you look at time, so this question of when and like what might you see over time, that this is from the Life Coach pregnancy cohort. And we looked at this at urine measurements that are collected at 4 different time points across pregnancy. And the question comes into play, do you see differences across pregnancy? And you do. So these 2 urinary phthalate metabolites, one comes from things like nail polish. The other, again, is that fragrance-associated chemical metabolite. And what you're seeing here is, for example, the Hispanic population remains high across the board for the kind of nail polish and other kind of associated phthalate metabolite, whereas for the monoethyl phthalate, the fragrance-associated chemical, you see both the Black and Hispanic populations having high concentrations, and you see this change. And I think this is important, this mid-pregnancy shift where there's a decrease. And that also, this is a non-persistent chemical. So there's something happening. And when we dove a little more deeply into it, and I'll circle back to this shortly, there's a change in behavior that's happening within this population that may impact the concentration levels that might have down the line some impact on health. So I'm switching now to PFAS, a persistent chemical commonly used in a variety of consumer products as well as occupational exposures, such as firefighter foam. Contaminated water is one of the primary sources in which we are exposed. And some years ago, when I first started studying this, I remember folks saying there's no inequity, everybody's exposed to this. And I was really curious about that because I don't know that that's wholly true. And there's been some studies that have come out even within the last few months that have shown that actually it does matter. Like there are differences by socioeconomic status and so on. This is showing place-based differences. So it depends on where you live, on whether or not there are exposure differences, and that has real effects. So again, thinking about what we might message differently with respect to that and how we might solution differently. Okay, so let's get to our traditional questions. What do we commonly ask? I'm an epidemiologist. I often think about how an exposure is connected to a particular outcome. So what the association might be, who might be at risk, and so on. And so see, these are some of the data that come from some of the studies that I've done looking at the associations between things like phthalates, those non-persistent chemicals that are used in consumer products. And I'll note they're used for their ability to hold fragrance in or to be able to flexibly bend plastic and so on. And we were interested in looking at this as it related to gestational diabetes risk. So we looked at multiple time points in pregnancy. We're not just exposed to one phthalate, we're exposed to mixtures of them. So we use a variety of mixtures, models, and techniques to do this. And so understanding what the association is, we saw that, for example, there was a 2-fold increase risk of having impaired glucose tolerance if you were exposed to the highest concentrations, the highest quartile of these butyl phthalate mixtures. And again, these come from a variety of sources. For example, it's also worth noting, I know that this department is very strong in worker health. And so gestational diabetes is a condition that is much more prevalent among Asian and Hispanic individuals. And when we're thinking about workers' health, the population that, if I mentioned that these are coming from, among other things, nail polish, for example. So when you think about how folks get siloed into certain professions, the nail salon industry is made up of 80% Asian individuals that are of reproductive age and female. So thinking about like what we might consider in the context of this. We also see that time period matters. So the when matters. So we see very different associations if we're looking at urinary phthalate metabolite concentrations that were measured in first trimester compared to second trimester. And so here what we're seeing is kind of a more insulin sensitive association if you're looking at first trimester for the highest concentrations, whereas second trimester, the time period in which the placenta has fully formed, and now you have the release of placental lactogen and other hormones, that now the body has to somehow overcome that. and not go on to develop gestational diabetes, that these chemicals may really impact the ability for the body to kind of naturally overcome that in that, after the placenta has fully formed. So that's kind of, and we've looked at this a number of times and have seen similar associations. We also, you'll hear me talk a little bit more about the role of effect measure modification. I often say to folks, it's necessary, but it is not sufficient for doing health equity related work. So here what we've done is we looked at, and I mentioned that Asian individuals as well as Hispanic individuals are much more likely to develop gestational diabetes. In fact, Asian individuals have among the highest risk, and this is looking at a population from the TIDE study. And it's only Asian individuals that have that increased risk with these butyl and monoethyl phthalate, which are kind of personal care product chemical associated urinary phthalate metabolites. And, again, thinking about what might be driving these differences. So this is looking at the association, again, that same study that Kelly Ferguson and Barrett Welch did, and looking at this as it relates to preterm birth. And I'm just showing you that we do see that there's an increased risk for the butyl phthalates, particularly as it relates to preterm birth in this cohort of about, or combined cohort of about 6,000 pregnancies. If we transition to thinking about PFAS, this is data from the Project Viva birth pregnancy cohort. And here what I'm showing you is that we were interested in looking at hypertensive disorders of pregnancy. And so we found that, again, these persistent chemicals were associated with a twofold increased odds of developing gestational hypertension. We don't see that for preeclampsia, and these have different mechanisms at play. But what might that mean when we're thinking about things like maternal mortality? And we know that cardiovascular, cardiometabolic related factors are the leading cause of maternal mortality. And we're really, kind of pressed on this issue of what to do with PFAS, for example. But it goes beyond pregnancy. And I showed in that very kind of like, I think, a second slide where it's not necessarily just in the time period of pregnancy, it's outside of pregnancy as well that we see these differences with respect to maternal mortality and cardiovascular disease risk. And what I'm showing you here is looking at data, again, from Project Viva and looking at pregnancy PFAS concentrations and then various associations with respect to cardiometabolic health at the 3-year time period. What happens in a time period? These folks are still young, but they're starting to develop cardiovascular related risk factors. What might be going on? And so we see associations with higher inflammation, as well as adiponectin and leptin. And so there's something about pregnancy, even in the context of thinking, again, we're only measuring pregnancy concentrations. We're not measuring concentrations outside of pregnancy. And we have an R01 where we're looking at what happens after pregnancy, because we're able to follow folks up to 20 years following. And we, interestingly enough, are seeing very similar associations, even in the context of like change from pregnancy to the midlife period. Here, we're just looking at midlife adiposity. And what is worth noting is, again, I'm setting this up, early pregnancy. So this is the index pregnancy. 17 years later now, we're looking at whether or not folks are bigger, have larger waist circumference, and so on. And what we find is that PFOS, PFOA are associated with higher BMI 20 years after measurement, okay? And a variety of other adiposity-related outcomes. So again, these persistent chemicals that we really need to think about in the context of now, today, but also what health outcomes might we want to be thinking about and setting ourselves up for, being nimble enough to kind of measure and assess and be key on solutioning together. Someone might say, you're an epidemiologist, that's all associations. So I think there's importance of building collaborations with folks and teams across disciplines. This is work where I had an opportunity to build and develop relationship and connection through some center-based work across a number of institutions with Marissa Terry, who is at the University of Rochester Medical Center, and she's a neurotoxicologist. And I said, she was used to studying these chemicals and just looking at the offspring's outcomes. And I said, why don't you keep the dams alive? Don't sack them afterwards. Like, what happens to them in their midlife? And so we had a chance to explore this question together with her student, Alyssa Morrell. And what I'm showing you here is, so they're only dosed with a chemical mixture that is human relevant. It contains PFAS. It contains several other of these endocrine disrupting chemicals that I mentioned. And she didn't sack them after pregnancy. So she only gave them this in their chow throughout pregnancy, stopped, and then kept them alive for about 6 months after, which is roughly our midlife. And she then did glucose tolerance testing and measured their lipid levels and so on. And I'm showing you that those that have this endocrine disrupting chemical mixture have elevated postprandial. So after you eat, the spike in your blood glucose level that's indicative of insulin resistance. They have elevated glucose levels, significantly higher cholesterol levels, as well as altered adiposity measures. So going back, I showed you a model where we were just looking at the association in Project Viva, but this is actually looking to see whether or not in an experimental study design, here the purple represents more visceral fat. So the mouse that actually had the EDC mixture has more visceral fat, which is the fat we don't really want. So, what might mechanistically be at play? So I think there's importance to like thinking across, labs, partnerships, ways in which we can engage with one another to do this type of work. Okay, so hopefully we talked through some of the traditional questions that we can ask and ways that we can intersect with each other to answer those traditional questions. But what about building solutions? How can we get to the why? Why might we see those exposure inequities that I mentioned to you all? And, why might there be, associations, and what can we do about it? What types of interventions might we be able to design? So this is a conceptual model that we published on a couple months ago, really thinking about ways in which our assignment to group membership, so social factors that we do just as human beings living in the world, are informed by historical processes that could be laws and policies, as well as contemporary processes and policies that are at play. And that can, assign folks to a particular ability level, appearance level, so on and so forth. But that there's these ways in which those factors, which we often use in our models as epidemiologists as covariates, we adjust away because we're, not necessarily interested in that. We're interested in whether or not the chemical or the heat temperature factor was associated with our health outcome. So we adjust that away, but we don't often think about the importance of how those things can be connected and driving. And in fact, there's not really a direct arrow. There's no reason that, the assignment of someone's appearance would somehow be influencing, like causing their environmental exposure. That doesn't make sense. And so thinking about this kind of, these structural factors, neighborhood and community level factors, and individual factors, and how we can do a better job of measuring and building our models to think about this. I think that we could start, for example, in thinking about behavioral factors. How might we be able to intervene at the individual level, for example? So we've been doing that. And again, going back to this particular example that I'm using, I mentioned that things like nail polish are places in which folks may be exposed to some of these chemicals. I mentioned fragrance as another source of exposure to some of these chemicals like phthalates. So this is specifically in line with the phthalate work. And these are data from the Life Codes pregnancy cohort. And what I'm showing you is differences by race ethnicity as one of those group membership assignments that we could have looked at. We actually in the same paper looked at socioeconomic status. We can look at other things, but you're seeing some differences, I think, in this very descriptive bar chart. And I think this is also the importance and relevance of doing exposure science, albeit sometimes very simple descriptive work that we could do. I'm going to draw your attention to differences with respect to hair gel, perfume, nail polish with both Black and Hispanic individuals using more of these things in pregnancy, and cosmetics being used more by non-Hispanic white individuals in pregnancy. So this was looking across pregnancy in that same population where we looked at gestational diabetes risk. There's also certain products, behaviors, things that folks are using that may be based on cultural practices. And so, about 20 years ago, we launched this study called the Greater New York Hair Product Study. And we were really interested in understanding the racial ethnic differences of hair product use and whether or not that was associated with earlier age at menarche, which we knew had a racial ethnic disparity. We also wanted to understand the hormonally active components that were in these products. And we wanted to understand the best way to ask this. And again, leveraging, thinking about ways that we can build as public health practitioners on different expertise. What we did was we leveraged, I was being trained at the time as a quantitative scientist, so we wanted to leverage qualitative science because oftentimes in the types of work that we're doing that's public health, we have to think about ways that we could do mixed methods research. And so we wanted to understand how best to ask people what they were doing and how they were using things. We learned things like people chopped up birth control pills, put them in leave-in conditioner, heated it up, and placed it directly on their scalp. Not what I would have thought people did, but hey, but a variety of things. We also were able to get a full list of what products people were using both at the present time and then also in the past in childhood. We conducted these in focus groups. And so learning how do you teach students to use focus groups and build their and kind of research expertise and hats that leverage mixed methods work. And so we recruited about 350 individuals and we validated this questionnaire that really ascertained information about what types of products, what brands, the frequency, duration of use, all of that. These are data that we published on showing differences by race, ethnicity, and you can see across the board for all the different product types, there were differences. And then we asked the question, what was in the products? Now it turns out, and this goes back to policies that were in place, and this is how policy may intersect with some of the work that we're doing. The Food and Drug Administration does not require, at the time of this study, the full disclosure of what was in these products. So there are some key things that you will find, like you will see fragrance on a product, for example, which can be synonymous with phthalates, for example, or you may see things like parabens, which are used as antimicrobials in products. So in looking at just the label and what is kind of typically included on the label, you see that about 50% of African Americans are using products that contained are labeled as containing these chemicals compared to only about 7% of non-Hispanic whites. We shared our list of commonly used products with Silent Spring Institute, and they were able to independently test these products and found that every single one of them contained multiple endocrine disrupting chemicals. It's worth noting that much research hasn't been done on some of these others, like alkyl phenols or cyclohexanes, for example, and more work is needed. And I appreciated John's point about, and the world just keeps throwing questions our way. But, what might we be able to do about this? We also wanted to understand the mechanisms that might be involved. So these aren't done in isolation. The previous work that we had done was just looking at one chemical at a time. But what happens if you look at these in mixtures form and the way that we use them off the shelves? And so we did a hormone receptor assay. Again, the importance of working across institutions. This was with our international collaborator, Lisa Connolly, at the University of Belfast. And she was able to basically, we sent our commonly used products to her, and it shows kind of across the board that things that are purchased off, just right off the shelf are able to either act or operate as agonist or antagonist of our body's major hormone receptors, some of which are involved in things like pregnancy, gestation, labor, and so on. But I haven't really proved my case about whether or not people who use products might have differences in the concentrations of their chemicals. So this is a heat map. The red represents high concentrations of, or higher concentrations of these chemical exposures, purple, lower concentrations, comparing people who use the products to those who don't use the products. And so across the bottom, you see the different types of personal care products folks are using. I'm going to draw your attention to hair oils. That was in the previous graph, one of the most prevalent products that was used. And folks who use hair oils compared to those who do not use hair oils had concentrations that were 125% higher. That's worrisome, but it's also something like an aha moment. Again, going back to that question of why, is there something we can do about that? I'm not trying to give someone a drug. I might be able to say to someone, use less or don't use this at all, for example. Before I get there, though, I wanted to know whether or not there's an association between hair product use, particularly hair oils and some of the other commonly used products, and clinical outcomes like gestational age or preterm birth. We measured this at multiple time points. People change their behaviors, but generally we do the same thing with respect to like within a given time frame. So we wanted to ask this question across pregnancy of hair product use, daily versus less than daily versus never use. And I'm drawing your attention to the last visit, so kind of closer to the time period of labor and parturition. And so what you're seeing here is daily users of hair oils in late pregnancy. This was associated with an 8-day earlier delivery. There are very few things that are associated clinically with an 8-day or that kind of magnitude earlier delivery. And so again, thinking about note, the less than daily users did not have that same association. So might there be something that we could say to clinicians who are seeing patients who often, when I give this type of talk to grand rounds, I usually start with, how many of you all have ever been asked, should I stop using, you name it? And it's often, yes, all the hands in the room go up. So might this be something that can be better integrated in? We also asked the question of whether or not there was an association between hair product use and birth weight. And what I'm showing you here are distributions of sex-specific birth weight for gestational age Z-scores within the study population. I'm showing that by daily users of hair oils, less than daily users of hair oils, but still users, and never users, folks who didn't use it. And you'll see that there's a shifting towards lower birth weight for sex-specific birth weight for gestational age Z-score, but also a widening, a thickening of these tails. And what that translates to is about a 300-gram lower birth weight among daily users of hair oils compared to those individuals that did not use hair oils. Again, perhaps an opportunity for intervention. But we often stop with the individual. And I showed you that conceptual model for a reason, because in our thinking about solution and solutioning together, it's really important to not put the onus, the burden on the individual. Like, after all, I don't know about y'all, but I go to a local store. If I turn something on the back of a container, it's a bunch of words that I don't quite even understand as a scientist. So how do we expect folks to be able to, alter behaviors and be able to make choices? So I have a really amazing doctoral student who's working with me, getting ready to graduate, and Marissa Chan, who asked this question of place-based factors. What does place matter? Does neighborhood matter? And so is it possible that it's not just the individual level, but what's available to the individual? So the average person does not purchase their personal care products online. And that's the part of the pushback we got. And so we actually dove into business related research, consumer product research, to try to figure this out. And it turns out most people purchase like their toothpaste at a local, big box store. So what's available in your community? And it turns out that if you are living in a community that has a higher percentage of folks who are below poverty, or a higher percentage of folks who are identify as people of color, you are much less likely to find safer products on the shelves. In fact, what I'm showing you here is the risk of having a product that has a high hazard score based on Environmental Working Group's Skin Deep database. And we are looking at one of the communities that kind of intersects with that. Mission Hill in the Boston area has a high percentage of people below poverty and a high percentage of people that identify as people of color. And compared to our wealthiest, predominantly non-Hispanic white community, it's about 2 to 2.3 times higher. They're more likely to find harmful products. It's also important to note how people use products, and this goes back to the intersection with qualitative research. So it's not just that people are using them, but they're using them repeatedly and not washing them off. So what happens when you're thinking about cumulative exposures in the context of this? Okay, so I think we've identified maybe a couple of ways that we can build out solution. So let's design a few things. That's what we decided to do as kind of the next step. But the first thing is, what methods should we be using? And I've already mentioned that maybe effect modification is important, but it might not be wholly sufficient. And why is that? So Joan Casey and I recently did a review of environmental justice literature. We were curious to know what methods folks were using and what factors people typically looked at in the context of thinking about environmental justice. Socioeconomic status and race were some of the most prevalently studied. So we are leaving a whole host of social determinants on the table when we don't study other things, and it's quite important to consider those. But it's also worth noting that if you're an epidemiologist, you're more likely, to use the tool of effect modification, which simply describes whether or not you see a difference in the association, but doesn't get at what you can do about that difference. In exposure science, there's more regression modeling that's used that may look at what's driving it, but how can we connect the two better to be able to think about this? One way to do that is to think about hypothetical intervention development and use. These are using G computation methods. This is also from a publication, same set of publications looking at phthalates and preterm birth. And the question was, what if we reduced the exposure in the non-Hispanic, Black, and Hispanic Latina populations down to the concentration levels that we were seeing in non-Hispanic white individuals? Now, there's a variety of ways that we could do that. We could do that through policy. We could do that through individual level, or as I mentioned, this neighborhood level interventions. But what if we were to reduce that? What impact would that have on the difference in preterm birth that we see, since we know that these phthalates are associated with preterm birth? And what I'm showing you here is that we may end up with roughly anywhere from a 9 to 13% reduction in preterm birth, which is helpful when you think about the fact that preterm birth, it's about a 50% higher risk of preterm birth among, for example, non-Hispanic Black individuals. So we might be able to offset that. So maybe we could incorporate these types of methods into our work more, for example. One of the things that we've done, though, is we've launched 2 randomized controlled trials, one called iHelp and one called DEEP. They are targeting clinicians and doulas to improve their environmental health literacy, recognizing that in medical school and nursing training, we do not provide environmental health as a core competency area. So in order to do that with folks who are currently practicing, we designed a set of narrative-based interventions that focus on phthalate exposure and sources of phthalate exposure, both from things like food packaging, but also from personal care products. And we tell this from a variety of perspectives, recognizing that the American College of Obstetrics and Gynecology has guidance around this, but that there's been limited implementation around how to get that guidance on discussing endocrine disrupting chemicals with patients. So we talk about this from the patient perspective, as well as working with our pediatric environmental health specialties units. Again, opportunities to build in and widen coalition based work to do this. This is some of just kind of preliminary data from this, showing that the way we designed this was a pre and post test. So we look at what is like a 35-minute intervention where folks sit for these modules where they're looking at the narrative-based patient perspective, the clinician perspective, the scientist perspective. We test their environmental health literacy, which includes things like awareness, issues around uncertainty, regulatory interest, and we combine this into a score that we call the PEARL score, or the Phthalate and Environmental Reproductive Health Literacy Score. And so you can see that pre-course versus post-course, we have a significant increase in improvement. We also see that that same score is associated with phthalate metabolite concentrations. And so folks who had higher levels of environmental health literacy had lower phthalate metabolite concentration. So it's an opportunity. If we can improve someone's environmental health literacy, we might be able to reduce their exposure and concentrations of to phthalates. I'll just bring your, noting to the biggest areas was around protective behavior risk control. We also do a lot of work in the context of environmental justice and community partnerships, and this provides opportunity for us to have a way of learning what community members are interested in and then designing studies. And I'm really happy to see my co-director of our Community Engagement Corps for our MemCare Superfund here. Some of the work that we've done is includes developing environmental justice curricula for late elementary through high school students, doing community events like listening to our community members' concerns around water, water safety, food insecurity, and personal care product safety. We have have an ongoing relationship with Africatown, Alabama, which is real concerns. It's an environmental justice community that has real concerns around air pollution and metals exposure in their soil. And then we have a social media educational campaign, and we've launched several modules within the environmental racism story map, which provide opportunities for folks across the board to engage with and learn more about the roles of environmental racism. We won second place in the 2022 ArcGIS story map competition for that. And then we also have a podcast that speaks to some of these issues. We have a boot camp, and if anybody's interested in learning more about this, it will occur this year again. This will be year 4 in August. It's really an academic research partnership across a number of universities that I was able to launch along with my co-lead, Dr. Joan Casey, to really think about how we can dive deeper into the methods around doing environmental justice research and, importantly, solution-oriented research. We've had a broad range of attendees, including departments of public health attendees from Washington State, all the way to ministries of health attending from Thailand and Nigeria. We also have been doing a lot of work in the context of policy, and so helping to really change laws and policies around consumer product use, including contributing to this work that's ongoing with this proposed FDA ban around formaldehyde, the Crown Act, and attention on policies specifically in the workplace and workers' health. And then thinking about ways in which we can provide tools and resources to workers, including salon owners and workers, and providing clinical guidance. So with respect to this PFAS committee. And so just taking this home, I think it's important in the context of thinking about ways in which we can really move forward towards achieving health equity or taking a health equity approach, is to think about ways in which we can partner and collaborate with one another to solution together, integrating in the social and contextual determinants, thinking about the barriers that we might have that may include improving environmental health literacy within populations that serve as key stakeholders. Also identifying place-based factors and ways that we may interact with the business community in a way that engages and leverages our educational expertise in environmental health. And lastly, thinking about ways that we can really build authentic trust with communities by thinking about ways that we can identify modifiable risk factors so that we're not just publishing in silos and republishing the same effort and work over and over again, but actually moving towards solution and holding ourselves accountable to doing that. So that our goal is to really achieve health equity for all. I'd like to acknowledge my research team, and I can take any questions.
Thank you, Tamara. And I'm sure we're going to have a lot of questions and discussion. For those of you who are online, if you put your questions into the chat, I will pass them on. So I'll start. And you've showed us a model and how you followed it through from the bottom of the pyramid to the top. Talk a little bit about how you see the generalizability of that model, and is it a template on which you think a Department of Environmental and Occupational Health might operate? And I will say that as you know, our faculty want to make a difference, and then they often struggle with, as you said, you've published, then what? So you have a day to answer them.
Wonderful. I've had an opportunity already to meet with junior faculty, some members in the department, as well as Jedi, which I still think is an awesome name, whoever came up with that. And some of, I've had an opportunity to really hear about the amazing work that you all are doing. I also got to read about it online and also work with amazing partners that are in the room. And you all are doing a lot of this already. So I know from work that you're doing, you're out in the community, you're making change happen already. The approach of thinking not just about publishing for the sake of publishing, you all aren't doing that. So the question from my perspective is, how do you make sure that faculty still have the resources to continue that moving forward? And how do we make sure that when we're training students, the next generation, that's, continuing to be embedded not only in the research experiences that students may have, but also in the curriculum, the coursework, and so on. So from my perspective, a lot of what I talked about is happening. I think what I would be encouraging of is an opportunity to build and continue to widen connection. How do you build in mixed methods more? How might you do more interventions? How might you use implementation science to evaluate whether or not those interventions are working? How can you cross-cut that with, whether you're doing climate, we talked about climate science versus, I spoke today about chemicals, but how can you do that and leverage? So being able as a supporter of making sure that faculty can plug in to different places and, ways to solution creatively together, I think is the key.
Great talk. And I really, it's so important to try, and when you're thinking about, addressing environmental injustices, really, how can we intervene? How can we actually make a difference? I'm wondering, for that sort of individual and public policy level interventions, if you're trying to address an environmental injustice or a disparity, how do you ensure the intervention itself doesn't sort of further widen disparities? A lot of sugar tax that disproportionately affecting people of lower SES who can't afford that extra tax anyways. Sort of in terms of, I guess, one of the examples that you brought up, you saw there was potentially an improvement in the rate of preterm birth if you could reduce the levels of those exposures among Black and Hispanic as compared to white levels, white non-Hispanic levels. But in doing so, how would you sort of address that to try and make sure that you're not actually having some other unintended negative effect?
Yeah, so in the context of the work I do, I think about this idea of chemical whack-a-mole. So, okay, you just swapped out phthalates, but you replaced it with something else. And, that whatever that is could be more harmful. So just to kind of play that example out a bit. So in thinking about how do we create safer products for everyone, I think there's something to be said about making sure that we can improve our process by which we vet whether or not something's harmful to begin with. So like being able to serve on those types of committees that are thinking about this and making sure our faculty have a chance to like really launch and leverage their voices, their expertise to do that is important. In the context of that particular like hypothetical example where we bring concentration, we don't have that disparity anymore. We bring concentrations down. It's not zero, right? It's everybody comes down to something that's lower-ish. What might we save with respect to that? What you don't want to happen is that folks start using the alternative and the alternative is more harmful and then you have another problem. So how might we be able to actually work within groups that, and design studies that look for safer interventions? You can't just say, stop using this. You have to have a alternative. So I think it's really important to kind of do research that looks at the both and. Like if I'm going to reduce, what are the things that I may be increasing? And that gets to my third point, which is the importance of working across expertise areas. So I mentioned like even in the context of, we worked with toxicologists. I'm working right now with an implementation scientist, but also working with, having opportunities to create these pods where you have a chance to collaborate with a business leader or someone who does educational curriculum development, and so on, to do the type of work that recognizes there's interconnectedness in the work that we do that doesn't just stop at public health. Does that make sense? Yeah.
As I came in late, so you might have already answered this, but I was wondering if you had an answer to the question about, so there was this discrepancy in exposures of personal products. Do you have a good answer to like why that's the case? Is it because those products are inherently different, or is it a cost saving measure, or why are those products, why do they have different exposure profile? And
It's a
maybe
great question.
policy of what you do about it.
It's a great question. And that is the next space that Marissa Chan is going in as a part of the research that she's doing. One of the things that I'll just build on from like kind of years ago, we were really interested in seeing what policy changes around this have been very hard. Last year, the Modernization for Cosmetic Regulatory Act came into play. And while there have been some improvements, there's going to be, for example, a rollout with additional disclosures for consumers. What is needed, many folks are in agreement, is not there, meaning that we would not put harmful chemicals into consumer products. And we would be more thoughtful about what we did put in based on the scientific evidence. But what was interesting was about, and again, this is the importance of recognizing opportunities to work with businesses, was that maybe about 10 years ago, we reached out to a major manufacturer of consumer products and said, you know, could we work with you all to help develop a safer set of personal care products for folks? And they said, there's absolutely no market for women of color to have safer products. They won't buy it. It's going to be too expensive. You know, the market data doesn't show that. So I'm not sure where they were getting that from. And what's been interesting over the last 10 years to watch and see is that there's been whole kind of like a cottage industry that's set up with kind of grassroots companies creating markets for this. And then these larger companies buying these. So I think that there was a sense that it's too expensive. But as I've said to folks, like if you go to the EU, these same companies are already manufacturing safer products for the EU. They don't do it here. So how can we kind of push for more change in that space, I think is important.
I'm wondering if anyone's looked a little bit at the marketing side of it. So, and this I'm kind of talking about for everyone. So there's a lot of marketing like to young people and using all these products. And it seems that the use of products is increasing and the number of products is increasing. And could we take lessons from what we've done with food and healthy food choices and potentially even tobacco in the market?
I absolutely think so. I remember, again, years ago, when we first started doing this work, and the question was, this reminds, I was talking to one of the researchers Julie Palmer over at the Black Women's Health Study, she said, this reminds me of a food frequency questionnaire. First of all, what you've designed is essentially a food frequency questionnaire. And second of all, you know, can we take, you know, some lessons that we've learned from other settings and apply this here? And I absolutely think so. I think the challenge is it's not one thing. So I think with tobacco, with cigarette smoke, and albeit it's much more complicated now with vaping and everything else, but back when that campaign first launched, you were really talking about cigarettes and people could readily see smoking. But you're talking about something that's on a shelf. I don't know about you all, but I go into the store. It feels overwhelming. It's like a sea of things. And now you're talking about hundreds of ingredients in there. And what one or multiple or synergistically, what in combination might be, I tell people with this whole FDA ban, it's really an issue of you have a kit. There's separate items in there, and then you mix them together. You're creating the chemical reaction that's releasing the formaldehyde. So it becomes much more difficult to message that in a way that then compared to, say, smoking. But do I think it's doable? Absolutely. And I think that's where the creative solutioning can come in.
I have an online question for you, and that is talk about collaborations that you see here at the Colorado School of Public Health that sort of whet your appetite.
Yeah. So I've been intrigued by the workers' health, you know, the expertise and that you all have that intersects with epidemiology and, you know, behavioral sciences and so on. But also, John, we've talked about the three, you know, different locations of the school and the expertise that each of those locations houses and has that can build on being able to solution in very creative ways that impact the community here in the Denver area, but, you know, San Luis Valley and beyond. So I'm excited about learning to, again, I'm going back to Jedi because we had a chance to kind of talk and think through, what are ways that you all are creatively coming together with university-wide initiatives, with school-wide initiatives, with department-wide initiatives that give a chance to expand and think beyond some of the work. And then there's also opportunity for being able to create pipelines. We had a chance, I don't remember the official name of that center that we walked through. Thank you. Thank you. I've been hearing some acronyms too, and I apologize. But there's opportunities to develop additional pipelines. I heard a lot that folks are interested for developing and having a more diverse student body, for growing in that area. So might there be chances for, the work that Kathy's doing, where in San Luis Valley to, she's continuing to teach folks that may not know what environmental health is, if she wasn't there, about environmental health. And it's a long-term process, but is that a pipeline opportunity? Is there a pipeline opportunity for, leveraging and working with relationships across the university that facilitate folks in, education or policy or engineering to kind of be plugged in more into public health? Some of that exists already, and that's exciting to hear. And then are there ways that we can build on that anew?
Officially, we're out of time, but that's not going to stop me from asking one more question. So if you think about the pyramid, and we've gone from sort of molecular structures and mixtures up to marketing, global things, getting FDA to do the right thing, and so on. How do we get our students prepared for this very complex world of trying to make a difference around environmental health?
I think there's formal and less formal ways to do that. So some of which I'm certain you're already doing. There's the in-class, work and opportunities to develop their expertise and their methodologies to be able to be effective scientists and public health practitioners. There's the research that you all are doing that provides experiences for them to dive more deeply into that work and to be connected to that work. And then there's opportunities for, them to exercise those opportunities outside this space, outside the classroom. So it sounds like you all have real connection to the Department of Public Health and other government organizations. You have real connection with, marginalized communities and populations where some of the students get a chance to go out and be in the field and collect and do that work, and to be involved in committee discussion on some of this. And so facilitating that. And I heard about a Grammy event that you all host. That was Oscar night. And so thinking about some of these informal opportunities where, I think as scientists, we sometimes think of ourselves as, I am a scientist now because I am here in this space. And when I leave from here and I go home, I'm whoever else. But the truth is that we're always a whole person. And so our students being able to see our why, what brings us here every day? Why did we come into public health? It is not isolated just to being the scientist. It's connected to all the science and questions that we ask. And so being able to show up authentically in the work that we're doing is important for them to be able to go out into the world and show up and make a difference. So I think that's Bear's way.